All right, everyone, I am live. I'm just going to check for sound here for a second, see how we're looking. All right, we sound good. So what I want to talk to you guys tonight about, I think, as I'm starting out this whole separate section of the channel and we're talking about research, and I put in a title, Why Therapists Do What They Do. So I think that's a good title to really go from. And I think what I'm going to do is, I talked about in the last video that I just sent out to you guys, my last recorded video, which is essentially on cartilage damage and different parts of the body and the different types of cartilage, and specifically what can you really do when you have a lot of cartilage damage and you're dealing with a lot of inflammation. So hopefully you'll check that one out. So this specifically, I think what we're going to do is just dive into, I'm hoping at least once a week, maybe twice a week, into why therapists do what they do in the clinic, and as well as, hey, why can't I not just do some of this stuff at my house? So I think that's what we're going to really focus on a lot. And so tonight I want to focus on one thing specifically, and in this is actually Cochrane Library. So if you ever want to look at this, this is a peer-reviewed journal. This is from the server PubMed, which is a lot of different research out there that's basically from PubMed. And really what this article is talking about is manual therapy and exercise for rotator cuff. So we're looking specifically at rotator cuff and also manual therapy, which is like massage, could be soft tissue massage, could be what we call cross friction massage, which is really dig in there and try and get that inflammatory process going. And this specifically was done, this is the newest one, this was done in 2016. So we want to look at the last 5 years. It really gives you a good idea of where the profession's going. And so this is a pretty recent article, even though it was 2016. It takes a little while to get this stuff vetted when you actually do a peer review research journal. When you get into a peer review and you get into a journal, there's a lot of steps that goes on to finally get your research article or paper actually into one of those journals. So the background on this is managing of the rotator cuff often includes manual therapy and exercise, usually delivered together as a component of physical therapy interventions. This review is one of the series of reviews that form an update of the Cochrane View, physiotherapy. So overseas, outside the intercontinental United States, we're considered physiotherapy instead of physical therapy. So the whole idea here is to really see, do these actually make a difference when we're talking about rotator cuff disease? Now, when we talk about disease, we could be talking about just inflammation, partial tear, complete tear. We're talking about that tendon is not working like it's supposed to, that rotator cuff. So this data was 2 review authors, independently selected trials for inclusion. And then this was performed with risk bias assessment, basically to make sure that, hey, I didn't say something and looked in the research and it sounded like this, or I felt like that. So this is taking all that biasness out of the equation, which you should do when you need. That's kind of one of the things right off the top, that when you're looking at a research, is there a bias or is it taken out completely? So in this article, they looked at, there was 60 trials, so there was 60 participants. Although only 10 addressed the main comparison of the interest, which was the comparing the two, which is manual therapy and therapeutic exercise. Overall risk bias was low and 3 unclear in 14 out of the high 43 trials. So they weeded out a lot here. So we were unable to perform any meta-analysis because of the clinical heterogeneous or incomplete outcome reporting. So what they're looking at here is they're trying to do an overall analysis of several different research articles specifically on this. So this is a very powerful research article that we're looking at right now. And so it looked over 22 weeks. So that's pretty extensive. So if we were looking at something and we're going to look at it's looking over 22 weeks. And that is a long time. So you figure in physical therapy nowadays, you might get therapy for maybe 4, 6, or 8 weeks. This research article is looking at different research that's done over 22 weeks. So that's a tough thing to go by, because the reality is almost no insurance actually allows any authorization. 22 weeks. 22 weeks of anything is quite impressive nowadays in the medical field. So in this case, they looked at 22 weeks. The mean change in overall pain in placebo was 17.3 points out of 100 points. So if they looked at people out of 100 point being the ceiling, being the best, they're looking at here. They said basically the confidence was 95%, which is amazing. Basically saying what they said was true 95% of the time. And they basically used a placebo for this. They also looked at the adjustment. So there was a 7-point adjustment, which was pretty. So they looked at 57% of the participants reported in treatment success with manual therapy and exercise, compared with 41% of the participants receiving placebo, which is, in this case, they didn't receive any therapy. So they looked at people receiving placebo, and then the other ones that were receiving both manual therapy and therapeutic exercise at the exact same time. So they looked at the ones that didn't receive it and the ones that did. 5 trials that also looked at, in this case, manual therapy and exercise compared to cortisone injection with respect to overall pain, function, activity, shoulder abduction, which is out to the side, and quality of life from 4 weeks up to 12 months. So they looked at if you got an injection with manual therapy and therapeutic exercise with a shoulder, and the outcomes they looked at was pain, how long you could move your shoulder out to the side, and the quality of life from 4 weeks all the way up to 12 months, so 1 year. And in this particular study, let's see, it came out to active shoulder abduction quality of life after 12 weeks was significantly higher with the shot than without the shot. So they had some groups with the shot, with therapeutic exercise and manual activity, and then they had ones with just the therapeutic exercise and manual techniques without the cortisone. So it was one with and one without the cortisone shot. 52 trials investigated effects of manual therapy alone or exercise alone, and the evidence was mostly very, very low quality. There was little or no difference in patients' important outcomes between manual therapy alone and placebo. No treatment, therapeutic exercise, ultrasound, and kinesiotape allow manual therapy alone was less effective than cortisone injections alone. So they looked at essentially taping, exercise, and manual therapy and versus just the injection. And then they looked at just manual therapy alone. And they said manual therapy alone was less effective than the injection. So you could have all this manual therapy you want, massage, trigger point therapy, cross-friction massage. And they essentially said the injection essentially outweighed improvement-wise, at least patient's improvement, the perceived improvement, which was based off of the quality of life, their pain, and abduction out to the side. There was little or no difference in importance in overall pain, but not function, when compared to the surgical repair for rotator cuff. So exercise alone led to less improvement in overall pain, but not function, when compared to surgical repair of a rotator cuff. there was little or no difference in patients' important outcomes between exercise alone and placebo. So there was no difference in patients' importance of outcome between exercise alone and placebo. Then they did, in this one, they looked at shock wave treatment, electrical current. Then they looked at the cortisone injection and arthroscopic decompression. Then they said, furthermore, manual therapy or exercise provided few or no additional benefits when combined with or physical therapy interventions, and one type of manual therapy or exercise was really more effective than another. So basically, they compared several things here. They compared exercise with manual therapy, and they compared surgery with the injection. And they said surgery with the injection showed no improvement. Therapeutic exercise and manual therapy showed no improvement when the patients also separately had a decompression type surgery in the shoulder and injection. So the injections and the shoulder surgery, there was really no benefit to having the exercise and manual therapy. So, author's conclusion, despite identifying 60 eligible trials, only one trial compared a combination of manual therapy and exercise effective of common current practice versus placebo. We judged it to be a high quality and found no clinical important difference between groups in any outcome. Effects of manual therapy and exercise may be similar to those of the injection and arthroscopic or subacromial decompression, so basically arthroscopic surgery. Adverse events associated with manual therapy and exercise are related to more frequent than placebo, but mild in nature. Basically, new combination of manual therapy and exercise should be compared with a realistic placebo in future trials. So, further trials of manual therapy alone or exercise alone for rotator cuff disease should be based upon a strong rationale and consideration of whether or not they would alter the conclusion of this review. So, out of all these different types of articles that were looked at, 60 of them in whole, which out of all 60, there was 3,620 participants. So that's a huge sample size. So out of all of those, they basically said, out of all those 52 trials, they were trying to really get a decent idea if therapeutic exercise and manual techniques combined or separately made a difference in the patient's outcome, their perceived outcome of improvement, as well as the reduction in pain, as well as the improvement in this type of movement here out to the side. And out of all those, they really couldn't figure out. Some of the research articles looked at injections and surgery. Some of them looked at exercise and manual techniques without the surgery to see if there was an improvement in those three categories: reduction in pain, perceived improvement in function, and shoulder out to the side. And then they really broke them down. Just the exercise, just the manual therapy, or just the cortisone shot, or just the surgery. And then they can try and compare all that with, hey, if I do exercise and manual therapy, is it even worth it? Is it worth for the insurance companies to pay for exercise and manual therapy when they have a rotator cuff disease and they don't have surgery? And they really couldn't come up with a good conclusion. They basically say here that I'm going to read the sentence again for you because this is the author's conclusion. Further trials of manual therapy alone or exercise alone for rotator cuff disease should be based upon a strong rationale and consideration of whether or not they should alter the conclusion of this review. So let me go to the background here. The rotator cuff disease is a common cause of shoulder pain. People in rotator cuff disease often describe their pain as being worse at night and exacerbated or increased by movement in specific directions, including overhead activity. It is often associated with loss of function, and some people describe as weakness. Manual therapy comprises movement of the joints and other structures by a healthcare professional, physical therapy or physiotherapy. Exercises include purpose movement, of the joint, muscle contraction, or prescribed activity. The aims of both treatments are to relieve pain, increase strength, joint motion, and improve function. So that's really the idea. So this was a huge study. And this, I'm breaking this down and trying to simplify it. This meta-analysis was 283 pages. So that's a lot. It was over, like I said, it's 3,600 patients overall over these 60 different studies. And so it really did break down. One good example here is 16 more people out of 100 rated their treatment as successful with manual therapy and exercise compared to the placebo. 16% absolute improvement, range of motion was 2% less, and 34% more improvement. So several of these studies, the patient had perceived improvement in their function. The range of motion really didn't improve, but their pain was less. So their pain was less, perceived improvement, but when they looked at the motion out to the side, objectively there was no difference, but subjectively there was. Patient had less pain, patient had perceived improved function in out in the world, but the telltale sign did manual therapy or exercise make improvement with a rotator cuff disease, and that was based off of this motion over the head. And these 57 out of 100 people said no. Side effects. 23 more people out of 100 people had minor side effects such as temporary pain after treatment with manual therapy and exercise compared with a placebo. So that could be a lot of things. So if they're trying to force a diseased tendon, because that's what the rotator cuff is, and that muscle to move, and it doesn't want to, it's going to give you increased pain. So that's one thing that they talked about. High quality evidence from one trial suggests that manual therapy and exercise improved function only slightly more than the placebo at 22 weeks. So these people had therapy over 22 weeks of manual therapy and exercise, and after that, there's little or no difference from the placebo in terms of the other patient important outcomes, which is overall pain, associated relative more than frequent but mild adverse effects. So that's a huge problem when we look at physical therapy and trying to justify it as, hey, we went this long with therapy, exercise and manual techniques, and there really wasn't an improvement. So this is all coming out of Cochrane. So this is Cochrane Library. This is from 2016, and this is all about manual therapy and exercise for a diseased rotator cuff. So there are a ton of scary things as a physical therapist when you're looking at this. Oh my, what's my takeaway? If I was the professional, and I am reading this article, and I'm looking at the meta-analysis, the data here, I'm looking at, yes, manual therapy and therapeutic exercise help in two things. They help in perceived improvement in function and reduced pain. And that's exactly what you'd want to get across to this patient when you're going to do, if you're looking at this type of diagnosis and you're looking at, okay, can I make a difference in their range of motion? More times than not, you're not going to. If the rotator cuff is torn bad enough, hence diseased enough, then you're not going to make an improvement in the range of motion by much. But you might make an improvement in their perceived function and reduction in pain. So that's where you'd want to really cater to and tell the patient. And what you want to do here, when you look at my stuff on my channel and you see the different treatments, and I'm looking under the shoulder category that I have up there, you really want to look at, hey, if my rotator cuff's bad enough, I'm really only looking to probably get reduction in pain and an improvement in overall function. But to see if my arm went really, really high, maybe it went like that and it won't go any higher. But my function's better. I can do a little bit more, but I really didn't get enough motion to really look at it significantly improving. And significant improvement, you're looking at least 10 degrees or more of motion of improvement to say, yeah, okay, I made a big difference. Because when one therapist measures this motion and another therapist measures that motion, you really got to give human error in there at least 5 degrees. So that's say, oh, I went up 5 degrees. No, it really needs to look at that you went up a solid 10 degrees to really make that you look like you've made a difference in your treatment, as well as what the patient's going to overall look at. So that's a huge thing I want you guys to take away is, yes, with rotator cuff, if it's bad enough, we're not talking about a strain. We're not talking like you slept on, you have a tendonitis. We're looking at a partial tear or maybe what we call a full thickness, or the thing is torn really, really bad or torn off. And you're dealing with something like that. You got this motion and that's it, and it's killing you. Okay, manual techniques and therapeutic exercise is going to reduce that pain within that motion, and you'll have perceived improvement function-wise within that motion, but you're not going to see a significant improvement in overall motion with that disease process. That's really what this research article looked at. So that is huge. If you guys have any thoughts on that, I'd love to hear them. This is a very strong research article. And on that note, I'm going to go ahead and leave you guys with that. So this is really my first live when it comes to looking at this. So I want you guys to take a peek on this. If you guys have any questions about this, I'm going to leave this up for the weekend as a DM in regards to this article. And like I say, until next time, look up. With Scully and I, he keeps smiling. You all have a good weekend. See you next time.